The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/MHP860. Downloadable slides and practice aids are also available. Thank you for listening to Peerview Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello everyone, this is Mark Crowther. I'm the chair of the Department of Medicine at McMaster University in Hamilton, Ontario, Canada, and welcome to this educational activity entitled Managing Bleeding Events in Patients Receiving Direct Oral Anticoagulants. When is it appropriate to implement reversal strategies in patients with GI bleeding? I'm joined today by my colleague, Dr. Truman J. Milling Jr. from the Seton Dell Medical School Stroke Institute in Austin, Texas. We're going to evaluate recent evidence regarding the clinical efficacy and safety of DOAC reversal agents, and we're going to review current guidance documents with respect to those that recommend the appropriate and safe reversal of direct oral anticoagulants, especially as it relates to gastrointestinal bleeding. The direct oral anticoagulants have really changed our approach to anticoagulant therapy. What's happened, as you can see from this slide, is that over the last 10 years or so, there's been a rapid and very profound increase in the use of the direct oral anticoagulants compared with warfarin. This is best illustrated by the fraction of the population treated with warfarin starting in 2011 and falling rapidly down to 2017, and the total fraction of patients treated with all of the direct oral anticoagulants starting at a low level around 22% back in 2011 and rising now to almost 90% and plateauing as there is a small group of patients who are going to continue to require the use of warfarin for prevention of thromboembolism, such as patients who have mechanical heart valves. But in general, the vast majority of patients who are started on new anticoagulants, as indicated by this slide, are started on one of the direct oral anticoagulants when it's indicated. On the next slide, we see that direct oral anticoagulants are associated with some interesting changes in the risk of bleeding compared with the traditional anticoagulants, that being warfarin. The most important change is that direct anticoagulants are associated with a dramatic reduction in the rate of hemorrhagic stroke, with a risk reduction of approximately 50% compared to warfarin. And as you would expect based on this, since intracranial hemorrhage has a high risk of death, there's been a concomitant reduction in the risk of all-cause mortality as the direct oral anticoagulants have gradually replaced warfarin. Interestingly, however, the risk of gastrointestinal bleeding appears to be similar, if not a little bit higher, with the direct oral anticoagulants compared with the more traditional anticoagulants, including warfarin. This is indicated in this forest plot by the bottom line where the diamond is on the right-hand side of the curve, indicating that the rate of bleeding, the point estimate, may actually be higher with the direct oral anticoagulants compared with warfarin. We won't get into the reason for this, but there's some strong biologic rationale why this might be the case. On this slide, we just present the event rates for gastrointestinal bleeding across the vast majority of the large licensing studies which were used for the approval of direct oral anticoagulants compared with warfarin. We won't go into this in detail, but you can see from this slide that the rates are in general above 1, indicating that the risk of bleeding is in fact higher with patients treated with a direct oral anticoagulant compared to patients treated with warfarin. And the consistency is around 1.2 to 1.3 in terms of the relative risk. So an increase of somewhere between 0 and 30% in the risk of GI bleeding. Importantly, we do not see the very nice and gratifying reduction in the risk that we see for intracranial hemorrhage. So although the risk of intracranial hemorrhage and fatal intracranial hemorrhage is reduced with direct oral anticoagulant therapy, we simply don't see similar reductions for gastrointestinal bleeding. On this side, we are identifying the important risk factors that are associated with the risk of GI bleeding in patients who are on anticoagulants. A history of stroke or of prior bleeding is obviously an important risk factor. Bleeding because one bleed begets another bleed and the underlying pathology can remain the same. And stroke because it's probably a marker of more intense and more focused anticoagulant therapy. The use of concomitant agents that increase the risk of bleeding, such as antiplatelets or non-steroidal anti-inflammatory drugs, are strong predictors of bleeding. As our advanced age, evidence of impaired organ function, particularly renal failure, but also hepatic failure, Anemia is a risk factor for GI bleeding insofar as it probably indicates chronic underlying bleeding, not that anemia itself predisposes to bleeding. And thrombocytopenia obviously predicts bleeding risk because platelets are necessary for both primary and secondary hemostasis. So with that introduction, I'll turn it over to Dr. Milling.
All right. Thanks, Mark. I've been studying reversal of anticoagulants for about 15 years, from all the sundry reversal agents that have come out, both in the warfarin era and now in the era of DOACs. And I'm going to go over some of the evidence for the reversal agents, their mechanisms, some real world applications, and then hand it back off to Mark for discussion of resource and utilization of these reversal agents in hospitals. Going over some of the real world evidence for DOAC-related acute GI bleeding and making the underlying point that few of these patients actually need a reversal agent. Most can be taken care of with hemostatic control through endoscopy. Many can be just watch and wait kind of patients because the DOAC half-lives are so much shorter than warfarin. And the drug, assuming their kidneys are functioning, the drug will wear off fairly quickly. And it sort of changed what we consider a major GI bleed in the setting of reversal agents because the drugs are safer overall and much quicker to exit the body when we don't want them there. So again, many patients don't require reversal. You don't need to get aggressive if the drug will be gone and you can address the bleeding in another way. But we always take care of patients who are at the sicker end of the spectrum, the patients who are in shock and perhaps massive hematemesis from a esophageal variceal bleed or diverticular bleed, where if there's a lot of blood on the floor, you might want to get more aggressive with reversal agents. So managing most patients treated with DOACs is a matter of transfusion and observation and eventual endoscopy by a gastroenterologist. Major bleeding, which was defined in relation to the therapeutic use of DOACs and was sort of extrapolated into reversal studies, first with warfarin using the ISTH criteria, for instance, with a 2-gram hemoglobin drop qualifying as a major bleed and potentially requiring reversal. However, in the DOAC era, we certainly did for the ANNEXA-A trials, we added some sort of minimum hemoglobin or some sign of shock in order to define the major bleed, because we realized that of that full spectrum of GI bleeding, the ones at the lower end who have 2-gram hemoglobin drops but aren't hemodynamically unstable really don't need a reversal agent. So when you look at the reversal studies like adairicizumab or ANNEXA-A, you're really taking, of the GI bleeds that are in those studies, you're taking the much sicker end, those who are in impending shock and hemodynamic compromise. If you need help in risk stratifying patients, I'm a big fan of MD-Calc and using the Rockall score or the Blatchford score or some of the others in order to communicate the degree of illness very quickly to the gastroenterologist of which patients he needs to scope in the next 24 hours, which he maybe should come in sooner, and which he needs to be there as soon as possible. Okay, don't let your eyes glaze over. We are going to put up the clotting cascade. You knew it was going to happen. It is a talk about blood thinners and clotting. So here it is. It's the simplest one we could find, but you need to understand the mechanisms of the drugs and the mechanism of the reversal agents. So warfarin first, been around since the 1950s. It blocks vitamin K epoxide reductase, which ceases the carboxylation of factors 2, 7, 9, and 10. So they're diminishing those factors, causing a therapeutic effect in terms of reducing thromboembolic events. PCC simply replenishes those 4 factors along with protein CNS. And vitamin K ramps up the liver's production by allowing the body to produce its own factors, but it works too slow for patients who are bleeding to death, taking several hours. The factor 10A inhibitors, and apixaban, betrixaban, edoxaban, rivaroxaban, all directly block factor 10A, the direct oral anticoagulant, interact with a single clotting factor, and that's how they achieve their therapeutic effect. And ANNEXA alpha is a modified human factor 10 molecule that is inert in terms of the clotting cascade, but binds avidly to the inhibitor, the factor 10A inhibitor, thus removing it so that your native 10A can function in the clotting cascade. And idarucizumab works only on dabigatran because it's a monoclonal antibody to that drug, and dabigatran, of course, interacts directly with thrombin or factor 2A. Here's idarucizumab. Again, it's that end of an antibody that binds to the antigen, and the antigen in this case is dabigatran. It's specific to that drug, so you can't use the monoclonal antibody approach to reverse a class of drugs. It's specific to a single drug, and idarucizumab only reverses dabigatran. Right, so there's Charlie Pollack's trial, REVERSE-AD, which was looking at idarucizumab, that monoclonal antibody fragment, antigen binding fragment, for the reversal of major bleeding and urgent surgery patients taking dabigatran. About half were urgent surgical intervention and half major bleeding. We study those in separate cohorts because the outcomes are a little different between a patient who's coming in bleeding versus one you need to do a surgery or cut on. And a significant proportion of them in the major bleeding cohort had GI bleeding. And the agent worked quite well based on the outcomes that the investigators chose, which were drug levels and biomarkers of clotting, such as the eccrine clotting time and the dilute thrombin time. You can see there was complete reversal in 97.5% of patients and cessation of bleeding within 24 hours in more than 2/3. This trial didn't have a clinical hemostatic efficacy assessment. The investigators just decided that their proposed effect was removing the drug, and what happened with the bleeding was irrelevant to that. Their rationale was that we get the blood thinner out of the way, and you clinicians can deal with the bleeding with a normal hemostatic mechanism. There we have some of the data on the time to cessation of bleeding, the number of thromboembolic events, which were quite low in the idarucizumab, right around 5% in the GI bleeding population. So andexanet alpha, I previously described the mechanism, which is fairly elegant, pulling off that GLA domain on one end and mutating the serine binding site on the other end so that it doesn't, one, bind factor 5, which would make it an anticoagulant, and two, cleave prothrombin to thrombin, which would make it procoagulant. Rapid onset. So prior to studying andexanet in bleeding patients, there were two really well designed and carried out randomized placebo-controlled trials in older adults. Of course, you can do a placebo-controlled trial in non-bleeding patients. It's a little bit of a harder sell when patients are bleeding to death to have half of them get a placebo. But you can do it in the human model in patients who aren't bleeding. Of course, you can't measure hemostatic efficacy, so to speak, because they're not bleeding, but you can really get a sense of what's happening with the clotting mechanism and with the drug levels. And you can see here that in the ANNEXA-A trial, ANNEXA-A for apixaban, ANNEXA-R for rivaroxaban, in adults 50 to 75 years old, we had this, the same effect, very rapid drop in anti-10A activity, which is a measure of the inhibitor. And then a somewhat rise at 4 hours back to what you see in the placebo group. It's not necessarily a rebound, it simply illustrates this fairly short half-life of the reversal agent, which is given as a bolus in a 2-hour infusion, and by 4 hours you sort of see the andexanet going away. I should point out that we didn't have a rebound in bleeding trial because of course the same thing happened in the bleeding patients. So we don't really know exactly what the optimal duration of reversal that is necessary in order to provide hemostatic efficacy. It appeared that the 2 or 3 hours in the andexanet trials was long enough to achieve hemostatic efficacy in the vast majority of patients, 82%. The ANNEXA-4 trial was the large cohort, single cohort, no control group, of major bleeding patients. So 352 total, 26% or 90 patients were GI bleeding, evenly split between upper and lower and unknown. And we tried to enroll patients who had some sign of hemodynamic compromise or shock. You can see the hemostatic efficacy was similar to the larger cohort at 85%, a little better. Defining hemoglobin as the indicator of success in controlling a GI bleed is a kind of a fuzzy business. It's not easy to do because these are sick patients who get crystalloids and other infusions that can change the hemoglobin as a concentration without being a direct indicator of bleeding. So it's a fuzzy scale, but it was improved. And with that, I'll hand it back over to Dr. Crowther to talk about when we should use DOAC agents in GI bleeding.
Thanks, TJ. I appreciate that, and thanks for the thorough review. When we talk about DOAC-associated bleeding, GI bleeding, or other forms of bleeding, the most important thing to realize is that prevention is the best medicine, and the most effective way to treat a bleed is to avoid ever having it. This is a common mistake that physicians make, particularly now with so many highly effective antithrombotic therapies, that we pile therapies on. And the most important way we do that is we have a patient who's on a direct oral anticoagulant, for example, due to atrial fibrillation, who then is also put on aspirin and prasugrel, or aspirin and ticlopidine, or ticagrelor. And it's because the physicians don't speak with one another, and very few patients actually have an indication for the use of 2 or 3 antithrombotic agents, but a remarkable number of people are on them. If a person's on a combination of a direct oral anticoagulant plus aspirin and or another antiplatelet agent, you should always make an effort to see whether or not they need to have the antiplatelet agent, because many patients are on them because they had a stent put in a long time ago and they no longer need those medications. And adding an antiplatelet on top of a DOAC clearly increases the risk of bleeding, and adding a second antiplatelet further increases that risk. It's also important to avoid unnecessary NSAID use. Patients who are taking their ibuprofen 2 or 3 times a day for every day are at high risk of developing GI bleeding. And to mitigate this risk to some extent, you can consider PPI prophylaxis when appropriate. And also just really talking to patients to make sure that they are doing things to avoid their risk of suffering a bleed. For example, gastritis from alcohol, common cause of GI bleeding, important for patients to really keep a close eye on their alcohol consumption when they're taking these drugs because of that risk. If we move to the next slide, the problem is reconciling current guidance on reversal agents for GI bleeding is, as Dr. Milling said, most patients who present with a GI bleed are going to do pretty well without receiving a reversal agent, but a fraction of patients are going to go on to have major or catastrophic bleeding, and some will die. And as you'll see, the risk of a person dying from bleeding when they're admitted with a GI bleed is actually still around 10%, even in more contemporaneous data. All patients who present to the hospital with GI bleeding should undergo risk stratification and, if required, should receive volume resuscitation. Almost every patient should undergo endoscopy, and the real question is, how urgent is that? In a patient who's truly exsanguinating, it may be more urgent. If a patient is stable, it may be delayed for the next day, because all GI bleeds are caused by a lesion in the GI tract. They aren't caused by the anticoagulant. The anticoagulant just makes the bleeding source easier to identify. Reversal may be required prior to endoscopy. Our GI colleagues are always complaining about poor quality images because we haven't adequately cleaned up the field. So the more you can do to reverse the anticoagulation before they go to endoscopy, the more likely you're to get a valuable result from the endoscopic evaluation. And reversal agents should be considered in all patients who have truly life-threatening GI bleeding, with the choice depending on the bleeding severity, the patient's medical condition, and the type of anticoagulant therapy. Most guidelines recommend specifically targeted DOAC reversal agents, but PCCs are oftentimes considered as an option for reversal of the direct oral anticoagulants. Important not to note because there's any good quality evidence that they're effective, but more simply because physicians, when they don't have an option, feel that they should do something. They want to have an error of commission rather than omission, and so they use PCCs irrespective of a really profound lack of evidence that they actually work. And then most importantly is that whenever a patient is admitted to the hospital with a bleed on an anticoagulant, it's very important to develop a plan for restarting anticoagulation. And the reason for that is really simple, and that is that patients' risk factors for thrombosis continue. Their risk factors for bleeding are often mitigated by the treatment course they receive in the hospital. And what you want to do is get the patients back on their anticoagulants to reduce their risk of stroke. Dr. Milling and I were on a call earlier today where we were talking about this risk and how important it is to make sure that patients have a plan to restart their anticoagulants, because otherwise patients will suffer avoidable thromboembolic events. When we talk about promoting, on the next slide, optimal utilization of the DOAC reversal agents, there's some real big challenges to the use of agents such as idarucizumab and andexanet, with idarucizumab used for dabigatran, as Dr. Milling said, and andexanet used for the 10A inhibitors. Some of the potential challenges include the acquisition of these drugs. There's also significant operational logistics. They are fairly complicated to draw up and administer. They need to be administered on very short order. They need to be administered in an emergency department. And that is a problem because we aren't used to administering complex medications in the emergency department on a routine basis, although it certainly does occur. And it's also important to make sure that utilization is appropriate. You want to have minimal controls over these drugs because you want to be able to use them urgently at 2 o'clock in the morning. But if you have a physician who's using a large amount and it's subsequently proven to be inappropriate, it's going to dramatically increase costs without any hope of providing benefits to the patient. The core tenets include utilization of a standardized system-level multidisciplinary effort that promotes shared stewardship of these therapies so that the pharmacy isn't mad at the physicians for overusing it and the physicians aren't mad at the pharmacy for limiting access. There's a number of strategies that hospitals can use to make sure they have a supply of these drugs, including negotiations with their respective vendors to alleviate the initial cost burden, and also keeping a very limited number of doses on hand, but making sure you have a way of rapidly resupplying should that be available. And presently, there is this new technology add-on or NTAP payment program, which is available for some expensive drugs. This is a really important adjunct to getting this medication paid for during the initial phases of its rollout to the population. And NTAP payments are something that should be carefully considered with your pharmacy department around the use of these drugs. Another strategy is the drip and ship strategy, which is to say that patients may not present to a hospital which has the optimal circumstances in place to be able to manage those patients. You may not have 24/7 endoscopy. You may not have the interventional endoscopy that's required to treat major bleeding. These patients should be assessed in the emergency department. They should be stabilized. The reversal agent can be easily administered, and then the patient can be sent to a facility that actually has the capacity to care for those patients. Because this is a complex area and these drugs are new, a number of different expert consensus groups have come together to provide guidance on how the anticoagulant reversal agent should be used. And on the next slide, we see a paper from the Journal of the American College of Cardiology, recently published, talking about some of the strategies. This is the American College of Cardiology. There are many others, and I would suggest that you find one and use it. I think that the core tenets, again, are going to be very similar between the different programs. All of the reversal strategies need to balance the risk of recurrent bleeding with the risk of thrombosis when you interrupt anticoagulation. This therapeutic decision-making process should consider the bleeding risk, i.e. how large it is, the site of the bleeding, the risk of rebleeding, and the risk of death or disability from bleeding, as well as the need for planned surgical procedures and patient willingness to undergo the therapy, as well as patients' ability to access the medication. And again, as I mentioned earlier, every single patient who has a major bleed should have a plan to reinstitute their anticoagulation, or should be written in the chart that the patient should never restart anticoagulation, so that later on, when the patient is being discharged from the hospital, the decision about whether to restart or not is not one that's made on the spur of the moment. It's one where there's been some significant thought given to it. So let's just move on to a case now. This is a theoretical case that we made up. It illustrates some of the points we've been discussing. So this is a 37-year-old woman who suffered an acute episode of pulmonary embolism. She was admitted to the hospital with COVID-19, was critically ill in the ICU, and was found to have a pulmonary embolism. She was started in the hospital on rivaroxaban at the usual therapeutic dose, which is 15 milligrams orally twice daily, and was then discharged home. As an outpatient on day 6 of therapy. She develops an upper GI bleed, which she notices because she starts to have hematemesis. She returns back to the emergency department. She's found to be hypotensive, has active hematemesis. There's bleeding observed. She receives the initial resuscitation strategy that Dr. Milling has talked about. The hypotension improves but is not eliminated, and transfusion therapy is ordered. Blood is on its way but is not here yet. And so the question is, is this a patient who should receive a reversal agent? And if so, what agent and what strategy should be employed?
Yeah, I think in most clinical settings, this would be an appropriate patient. Blood on the floor, hemodynamic instability, that you would order a reversal agent, and this being a factor 10A inhibitor, rivaroxaban, the appropriate first-line agent, it would be andexanet alpha, the aforementioned decoy molecule that binds the 10A inhibitor and takes it out of the picture so your native 10 can function in the clotting cascade. I think when there's a hole in the bucket and the bucket's empty and the patient's in shock, that's the most appropriate patient for a reversal agent. depending on the resource setting you're in and how quickly you can get things. But it's also important to keep in mind that it's going to take a while to get the reversal agent from pharmacy. So most of the time, this patient would be one you would order the reversal agent quickly, and the appropriate reversal agent for rivaroxaban would be ANNEXA-A.
And then TJ, not really a question that you deal with directly, but you deal with it indirectly. This patient has had a recent episode of pulmonary embolism. She's only 6 days of therapy. A common error that's made is that her anticoagulants are not restarted. So could you just give us your comments on how an emergency physician or a gastroenterologist might just go about making sure that the patient is considered for restarting anticoagulation, and then in this particular circumstance, those anticoagulants are actually started before she goes home again?
Yeah, I think that's really important. I think it's easy for acute care physicians to sort of kick the can down the road on restart, right? So I'm an emergency physician. I'm not going to restart them in the ER. It's not my problem. And then the GI doc says, well, I can't restart them right now. I'm just going to do my consult and she can go see her PCP, or the hospitalist might say the same thing. And then they ultimately don't get follow-up for 6 weeks or a month, and you have this person who's very recent pulmonary embolism, also COVID, which we know is a prothrombotic state, and only received 6 days, as you noted, of her therapy. So she's very high risk for recurrence, and she is unlikely in most healthcare systems to get rapid follow-up with a PCP or cardiologist to restart therapy. So I think we have to start that conversation in the hospital, even before the bleeding has stopped, possibly, get everyone on board thinking about it so that we can implement the restart as soon as clinically appropriate, which in GI bleeding is often 3 days to a week. 3 days is on the aggressive end, and a week is sort of the accepted strategy for restarting the anticoagulant, so that we can minimize her risk of dying of a thrombotic event after we pulled her from the jaws of death of GI bleeding.
So I'd like to thank everyone for joining us today, and just a couple of conclusions that I think we should draw from this presentation. The first is that the direct oral anticoagulants have almost completely replaced warfarin, except for a few exceptional circumstances. Some patients with very potent procoagulant states, such as antiphospholipid antibody syndrome, and patients with mechanical heart valves. In general, all anticoagulant therapy is associated with an increase in the risk of bleeding, yet we haven't yet discovered the magic anticoagulant that reduces thrombosis without causing bleeding. Even before specific DOAC reversal agents became available, the outcomes of DOAC-associated bleeds compared favorably to vitamin K antagonists, as we went through in some detail. The most feared complication is intracranial hemorrhage. This has been reduced by about 50% with the direct oral anticoagulants. GI bleeding remains just as common as it was before, perhaps at an even higher risk than it was before. Patients using oral anticoagulants may experience GI bleeding, and they may require reversal agents, which sometimes have to be administered before endoscopy, as Dr. Milling identified during the case presentation we provided. Reversal agents should always be reserved for truly life-threatening bleeding or critical site bleeding or major bleeding that does not respond to supportive measures. And when used appropriately, the specific direct oral anticoagulant reversal agents have been shown to be effective with good outcomes, although more investigation is needed, especially in terms of GI bleeding. It's also super important to note that PCCs, which are widely used to reverse direct oral anticoagulants, in fact, are not reversal agents, and there's actually very little evidence that they're effective. So we hope that you found today's presentation helpful, and we appreciate your attention and taking time from your busy day to let us share this important presentation with you, and hopefully provide you with some information on our thoughts on how anticoagulant-associated bleeding, particularly GI bleeding, should be managed.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MHP860. This activity is supported by an educational grant from Portola Pharmaceuticals Incorporated.